microphone. It's very good. Okay. Go on.
Okay.
Let's see.
This is Sani Abdouan. This is Sani Abdouan, audiovestibular medicine specialist and Egyptian. I'm working in cochlear implant center in Abha, Saudi Arabia. My presentation today is about the detection of prevalence of hearing loss in neonates admitted to neonatal intensive care unit. Could you see the slides clear? Very good. My detection of prevalence of hearing loss in neonates admitted to neonatal intensive care unit. This thesis was done. This study was done in 2017. Significant hearing loss is the most common disorder at birth, occurring in 1 to 2 neonates per 1,000 in the general population, and 24% to 46% of neonates who are admitted to neonatal intensive care unit. Due to problems such as prematurity, low Apgar score, infection, hyperbilirubin, and the risk associated with treatment strategies including mechanical ventilation, oxygen therapy, and ototoxic medications, infants in the intensive care unit face various problems including hearing impairment. Infants with respiratory failure may be treated with hyperventilation, which might compromise the oxygenation and perfusion of the cochlear organ, and auditory pathway, resulting in hearing loss. The use of ototoxic drugs, including loop diuretics and aminoglycosides, has been associated with increased risk of the cochlea to damage from hypoxia. Most of the children had received aminoglycosides and diuretics. When hearing loss is identified prior to 6 months of age and followed immediately within 2 months with appropriate intervention services, outcomes in language development and communication competency and socio-emotional will be developed significantly better when compared with the children with later identified hearing loss. The use of ototoxic drugs, including aminoglycosides, has been associated with increased risk of cochlear tooth damage. The cochlea is especially susceptible to ototoxicity because medications is retained for a longer period and in a higher concentration in the inner ear fluids than any other body tissue or fluid. Screening procedures to detect hearing impairment may be divided into 2 categories: behavioral and electrophysiological. Behavioral techniques produced a high number of false negative results. Electrophysiological procedures have greater sensitivity and include measuring the following auditory brainstem response (ABR) and evoglottoacoustic emission. Our aim of the work was detection of prevalence of hearing loss in neonates admitted to neonatal intensive care unit and identification the risk factors causing hearing loss in neonates admitted to neonatal intensive care unit. A descriptive cross-sectional study for detection of prevalence of hearing loss in neonates admitted to neonatal intensive care unit between January 2015 and January 2016. All the neonates admitted to an intensive care unit at the Hospital Al-Manif University in Egypt were included in the study, except those neonates who died or couldn't take medical consent from their parents. 138 neonates admitted to an intensive care unit between January 2015 and January 2016. 14 neonates of them died, and 12 neonates of them we couldn't take medical consent from their parents. And the study was carried out on 120 neonates. Information about the condition of each neonate was collected from the sheet of the neonate included in the neonatal intensive care unit and included sex, mode of labor, birth weight, gestational age, neonatal intensive care unit admission cause, NICU admission duration, craniofacial abnormalities suggesting hearing loss, positive family history of hearing loss, congenital hearing loss, and consanguinity. Presence of conditions including asphyxia, sepsis, respiratory distress syndrome, transient tachypnea of newborn, TTN, congenital pneumonia, congenital heart disease, or hyperbilirubin treated with phototherapy or exchange transfusion, mechanical ventilation, and antibiotic ototoxic therapy. Complete prenatal, perinatal, and postnatal history was taken. General examination and local examination for craniofacial abnormalities suggesting hearing loss. Otoscopic examination for vernix obscuring the view of the tympanic membrane. At the time of discharge from the neonatal intensive care unit, all neonates were tested for hearing loss using a transient evoked otoacoustic emission, followed by auditory brainstem response ABR using intra-acoustic Eclipse device. Parameters of the transient evoked otoacoustic emission included the intensity was calibrated at 83 decibel sound pressure level and 0.5 to 4.5 kilohertz frequency band, 3 of 4 frequency band and signal to noise ratio more than 3 decibel appearing required to consider the transient evoked otoacoustic emission present. Parameters for the auditory brainstem response ABR included rarefaction polarity and using alternating polarity and condensation, rarefaction, and alternating polarity in case of auditory neuropathy, suspension, or auditory dyssynchrony, auditory neuropathy spectrum disorder. A click rate of 21.1 clicks per second and an intensity of 90 decibel NHL to get identifiable, repeatable ABR wave at 90 decibel NHL in case of present transient otoacoustic emission, and down 20 decibel step in case of absent transient otoacoustic emission. The low-pass filter was set at 1.5 kHz and the high-pass filter was set at 100 Hz with 1,200 sweeps and no sedation used in the study, just natural sleep. The result is normal in the hearing test repeatable at 90 decibel NHL with present transient otoacoustic emission, or identifiable, repeatable ABR wave 5 at 30 decibel NHL in case of absence of transient otoacoustic emission. The result was considered hearing loss when the hearing test showed absence transitive acoustic emission was neither identifiable nor repeatable ABR wave 5 at 30 decibel NHO from mild to severe to profound hearing loss. What about auditory neuropathy or auditory dyssynchrony? Suspicion was considered when the hearing test showed present transitive acoustic emission, presence of cochlear microphonics, and neither identifiable nor repeatable ABR wave 5 at 90 decibel NHO. So let's move on to our results. Among the 120 neonates included in the study, 80 neonates, which is 71.4%, showed normal hearing. 28 neonates, which is 25%, showed hearing loss, ranging from mild to severe to profound. And 4, which is 3.6%, showed auditory dyssynchrony or auditory neuropathy suspicion. This table shows the percentage of normal hearing loss and auditory neuropathy. Relation between hearing loss and risk factors or the included criteria. This table showed that there was significant, no statistical significant relationship between hearing loss and sex. We have to look to the p-value here. This table shows that there was no significant relationship between mode of delivery and hearing loss. This table shows that there was significant relationship between gestational age and hearing loss. This table shows that there was highly significant relationship between birth weight and hearing loss. This table shows that there was no significant relationship between neonatal intensive care unit admission duration and hearing loss. This table shows that there was significant relationship between ototoxic medications and hearing loss. This table shows that there was highly significant relationship between oxygen therapy by mechanical ventilation and hearing loss. This table shows that there was highly significant relationship between hyperbilirubin and hearing loss. This table shows that there was highly significant relationship between burst asphyxia and hearing loss. This table shows that there was significant relationship between craniofacial abnormalities and hearing loss. This table shows that there was significant relationship between positive family history of hearing loss and hearing loss. This table shows that there was highly significant relationship between consanguinity and hearing loss. In conclusion, we would like to stress the importance of identifying neonates with hearing disorders, administering early treatment, strict control of serum dose of ototoxic drugs is an important means for preventing hearing loss due to ototoxicity. Genetic counseling before marriage or pregnancy is necessary if there is familiar history of hearing loss. Children who are diagnosed with hearing loss would receive treatment by 6 months of age, a hearing aid fitting or even cochlear implantation by 12 months of age, as early identification and early intervention gives chance for infants to acquire speech and language. And finally, public awareness about the value of neonatal hearing screening is completely important. A team of obstetrician, pediatrician, speech therapist, audiologist is needed to identify the risk factors.